We go to the next talk on referral for laser, when and how. So this graph shows the natural history of ROP. Usually at whatever gestational age the child is born, 24 or 28 or 30, the ROP usually sets in by 32 to 34 weeks. So you start screening the child according to the Western thing by 31 weeks post-conceptional age, and then when the child reaches by around 36 to 38 weeks is when the treatable ROP develops. So these are all the timelines which are very important, that around 37 weeks you have to have an exam, because if it is active there, treatable, that is the time where you have to treat. And after that, if it's regressing, it's going to regress, but if it's progressing by 42 weeks, it's going to progress for stage 5 ROP. So you start screening by 31 weeks post-conceptional age, and 35 to 36 weeks is a critical time to 38 weeks to see for treatable ROP. But the easy way, what Dr. Parijat has said, that 30 weeks after birth, if you do all the screening, so it should cover up. So coming to the management of ROP, we have the cryotherapy, then we have the laser, and now the anti-VEGF also has set in. So these three are treated at a time when you can avoid blindness. But unfortunately, if it goes beyond threshold stage or anything, then surgical intervention is only required for, and then it will be sort of a permanent blindness. So the ICROP classification gave the stages, but they never said when will you treat for ROP. So the indications are, the old treatment indication was the threshold ROP, and now it has been revised to the high-risk pre-threshold ROP. So threshold ROP was given by the Cryo ROP study way back in 1988. And this was the cutoff for treatment. It is defined as stage 3 ROP in zone 1 or 2, having more than 5 continuous or 8 cumulative clock hours with plus disease. So we used to wait for threshold to develop and then treat, but then a lot of people knew that waiting so long also would be detrimental. So then the ET ROP came with the fresh guidelines in 2003, where they revised the treatment guideline, and they said that let us divide pre-threshold ROP into 2 types: the high-risk pre-threshold, the type 1, which is now the cutoff for treatment, and the low-risk pre-threshold or the type 2 ROP, which you can wait and watch. So high-risk pre-threshold, this is the new cutoff for treatment. It is zone 1, any stage with plus disease, or zone 1, stage 3, even without plus requires treatment, and in zone 2, if you see stage 2 or 3 with plus disease. So it reduces the confusion of clock hours involvement, continuous, non-continuous, and it has made a little bit more easier to do the treatment. And the type 2 ROP, the low risk threshold, it is zone 1, if you see stage 1 or stage 2 without plus, or in stage 3 without plus, then these can be just waited and watched, and then if they progress to type 1 or to threshold, then they require treatment, but they can be just safely, just a close observation of 5 to 1 week. So this table shows what to treat. So in the easy way, if there is zone 1, no plus, only stage 3 falls in the treatment net. Zone 1 plus any stage, stage 1, stage 2, stage 3, then it requires treatment. Zone 2, no plus, no treatment. Zone 2 plus stage 2, stage 3 require treatment. So the management is you ablate the ischemic peripheral retina with laser, which stops the release of angiogenic factors. And cryo was the earlier one, where you use the cryotherapy to give multiple cryo burns from the ridge to the aura. But the biggest disadvantage was that it requires general anesthesia, and there's got a lot of lid edema and periorbital swelling, especially if it's a posterior case you're treating. So laser is a more practical alternative. It is a direct treatment from the retina from inside, unlike cryo, where you do a conjunctiva, the sclera, the choroid. That's why the inflammation is too more and causes less local inflammation. The biggest advantage then, it can be done under topical anesthesia. However, you require an emergency backup. You cannot just do it like any OP case, like a diabetic. You have to have the emergency backup, and a pediatrician or a neonatologist should be around while you're doing the laser. If you're doing in the eye hospital, the ideal way to go to the NICU and do it when the nurses are there, that would be the ideal way, the scenario to do the laser. So this is the laser, the diode red laser is the preferred laser, and just to show that you require emergency backup while you're doing, even if you're doing a topical anesthesia. and the child has to be kept fasting for around 2 hours before you start the laser. In case if any emergency crops up, then it's fasting child is always better. So you have to monitor the child, the saturation for everything. And to keep the child warm, now sometimes the ACs are on, and then the surgeon becomes uncomfortable and all, and you have to keep the baby warm. So this is an infant warmer which is available called Embrace Nest, which is not very expensive and it is reusable, and it can be charged over 30 minutes, and when it's ready, you take out, this is a wax based pack which you put it inside this jacket. So this is used by the neonatologists when they are transferring a child from one NICU to the other NICU in an ambulance, but it is very helpful to keep the child warm. So it maintains a 36 degrees Celsius temperature for 4 hours without any electricity, so it's mobile. So with this you can see there's a check here, you can check that if it's ready. So if it's a rainbow colored line here, it is okay, so you can go ahead and you can use this, and it maintains the temperature for 4 hours. And what this helps also, it wraps the child nicely, so the child won't move much. And so the child is comfortable, even the surgeon is comfortable, he can keep the AC on and the child is still kept warm with this. And we usually give a sucrose for the child to suck during the laser. Sucrose is not available, so we use 25% dextrose actually, and then things become much more easier to do. So this is how it looks, the Embrace Nest. These are the 3 parts. This is a chargeable machine. It charges this and warms the packet. So these are all reusable. It's a permanent investment, and only this thing has to be changed every 1 or 2 years, and it's not very costly. And we use this for doing surgeries also. When there's a centralized air conditioner and the baby has to be kept warm during surgeries, we use this in the theater also. So this is a small video which I borrowed from my colleague in Los Angeles, and then this is how the laser looks. You see the aiming beam here, this is the ridge and the stage 3, and you start giving grade 2 to grade 3 burns to the entire avascular retina, and it should be near confluent. It's not like diabetic retinopathy where you give one spot width apart. It should be near confluent, and the entire avascular retina has to be finished in one sitting. Unlike in adults, you take 2 weeks and do the other sitting, you cannot wait, and both the eyes have to be done simultaneously. So this is a case which we are showing that we're doing the laser for 2 eyes under some sedation. So just a word about the anti-VEGF drugs. Now we know that bevacizumab and ranibizumab has been extensively used, especially bevacizumab, and the only randomized trial which is available right now is the BEAT-ROP trial, which was published in 2011, and it showed that the bevacizumab monotherapy as compared to conventional laser showed a significant benefit in zone 1 but not in zone 2. So I presume it shows that it works well on APROP, but if it's a conventional stage 3 ROP in zone 2, then laser can as well be done. So these are some cases of an APROP, a severe APROP of fluorescent angiography, which is showing that the capillary dropout is still a disc margin. Now obviously you cannot do laser in such cases. You cannot even save the fovea. You will have to burn the fovea to come to reduce the vascularization. So in such cases, if you attempt laser, this is what you end up doing, because this is a case which is referred from outside, and you don't know where the vascular and the avascular retina is, and then you invariably hit the fovea, and this is an extreme bad outcome which you don't want to see. So this is where the anti-VEGF works, and you can see the capillary network is growing in 2 weeks post-Avastin, and at 3 months it has gone to the periphery in zone 2, and so this, what we have done is a rescue treatment, where now the fovea is vascularized, and now even if new vessels come here, we have no hesitation of doing the laser in the future. So Avastin is used for these extreme cases of APROP, where even the fovea is avascular. So the current indications of anti-VEGF is mainly the APROP, and we can use an adjunct when the standard laser treatment fails, the ocular hypotony or progression despite or late reactivation. So in conclusion, so in 1980s we had the cryotherapy, which was very popular, and then in 1990-2000 the laser came, and with the laser the cryo disappeared, and now with 2010 with the anti-VEGF there, So the question is it going to replace laser? So the answer is, for the fight between the anti-VEGF versus laser, so who's going to win? A fight between cryo and this thing, the laser one, cryo lost, anti-VEGF and laser. I think they'll just fall in love with each other. I think they're already falling in love, get happily married, and then both are going to live together happily ever after. So it's not going to replace laser, but there is a role of anti-VEGF and there is a role of laser also, and it has to be just fine-tuned between the which one. So thank you so much. So if there are no questions, I